Or something?
Yeah, I think it was about that.
Board of Health meeting to order. If you could rise for the pledge, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Can we have roll call, please?
Klink, present. Richards?
Here.
Smith?
Here.
Hayes? Bulk? Present. Standell?
Here.
Urban?
Here.
Okay, we have citizens wishing to address the board. Dawn Davy. You're fine.
Good morning. It's chilly morning. see that we're working on CHNA and CHIP and discussing it. Which I'm not quite sure what the memorandum is and how this is going to work. I have to keep going back to the meeting where there was questions about the CSCD and that they weren't answering to this board or the medical director. And to that, I guess the first thing that I would have to ask is, how does the harbor, Goodwill Industries, community enterprises, Water Transportation, Habitat for Humanity, just a few examples, factor in to any decisions made medically through this advisory board? That I don't understand. And for transparency and accountability. And I'm just gonna put it out there that how many people here didn't realize anything, who didn't know anything about the CSCD, first realized it after FOIA requests were submitted and realized that Deb Johnson sat on the CMH board? Would this have even been a conversation if that full body board had decided to make Scott Crawford the chair for the CSCD? This is supposed to be countywide, especially when it comes to community health needs and CHIP. If we're going to focus on areas that we agree with and ignore those that we don't agree with due to, I hate to say it because it makes me crazy, political agendas, how does that help anything come? These are important things that this board and the health department need to consider. The whole instead of the few. And again, like I said, the harbor, Goodwill Industries, where my daughter's working now, does not factor in and shouldn't be an issue for this board or the medical director. Thank you.
Thank you.
Have a good day and try to deal with Mother Nature. Have a great one.
Kier, did you want to speak here? Okay. Carol Miller, followed by Anthony Farrelly.
Good morning, everybody. Over the
morning.
past several months, I have attended many ABOH and BOC meetings. I have sat quietly recently, listened carefully, researched, and yes, I am a clinical data research nurse by trade. I've reread documents and spoken directly with individuals to better understand what has been happening. What I've found is that there are often significant differences between what is said publicly and what the facts appear to show when examined more closely. That concerns me deeply, and I know I'm not alone in that concern. I have also witnessed behavior that has no place in public service or public meetings, behavior that has created division, disruption, unnecessary hostility. Public service should be rooted in professionalism, respect, accountability, and leadership. When those things begin to break down, public trust breaks down with them. But today I'm not here simply to revisit the past. I'm here to talk about accountability and leadership. Mrs. King, when you stood at this podium before the Board of Commissioners, you acknowledged mistakes, you accepted responsibility, and committed to making corrections. That matters. Accountability matters. Leadership matters. In healthcare, in government, and in public service, when mistakes happen, the expectation is simple. Acknowledge them, correct them, learn from them, and move forward, which you have. That is how trust is rebuilt. Leadership positions come with responsibility, and that applies at every level. Ms. Bishop, as leader in nursing management, many in this community have looked to her for professionalism, calm leadership, and accountability during difficult times. Instead, we have seen no accountability, no apology, no oversight, or no mistakes for the oversights that Mrs. King had acknowledged. Whether intended or not, leadership behavior sets the tone for those around them. And when concerns continue without meaningful accountability, trust continues to erode. Mrs. King, what I'm asking of you today is simple. Help bring an end to the division, the drama, the misinformation, and the public hostility that has surrounded these issues. You and Dr. Nevin have been working to make changes that will benefit the county and strengthen the public health department and returning the department to its core mission and ensuring that clients receive care and resources where they can best be served. The public deserves to see unity, professionalism, transparency, and accountability from everyone in leadership. Not conflict, not finger-pointing or unresolved division, but one focused on public health, not public drama. So today I ask you, Mrs. King, please make it clear to the county citizens that accountability applies to everyone, that professionalism matters, and that this division ends here today. Let us move forward as a community with one goal, to support a professional, accountable public health department that serves the people of this county with the core values it's supposed to, with integrity, respect, and trust. Thank you.
Thank you. Chair and members of the board, I'm here to speak in support of Dr. Remington Nevin, a medical director who brings rare conviction and careful thought at a time when those qualities are much needed in public service. In a system that can sometimes favor automatic consensus over inquiry, Dr. Nevin has consistently chosen to examine the evidence and the hard questions, even when that is unpopular. His record in St. Clair County reflects that. As medical director, he has worked to align our vaccine exemption process with Michigan law, actually provides giving parents real access to options the law intends. He has pushed our health development or department to focus on its core responsibilities rather than continually expanding school-based services that can drift beyond public health functions. And he has taken environmental concerns seriously, including potential impacts of large solar installations on community well-being, urging cautious evidence-based approach. These are the actions of a physician epidemiologist trained at Johns Hopkins, board certified in public health and general preventative medicine, and experienced as a U.S. Army officer. Long before he came to St. Clair County, Dr. Nevin challenged widespread use of certain anti-malarial drugs used in the military, documenting lasting neurologic and psychiatric side effects in service members. He helped define and publicize conditions known as quinism, testified before legislative bodies, and has contributed to stronger FDA warnings and changes in military policy because the data demanded it, even when powerful institutions preferred the status quo. This is the kind of leadership he has brought here, a willingness to be criticized rather than compromise on evidence, informed consent, and local control. Scripture, the Bible, reminds us that we must obey God rather than men when conscience and duty call us to stand for what is right, even at personal cost. In recent months, Dr. Nevin has faced scrutiny and opposition precisely because he is willing to challenge assumptions, yet he remains focused in what he believes to be good for the people of St. Clair County. My own interactions with Dr. Nevin, I have found him to be thoughtful and respectful and deeply attentive to the people he serves. Thank you for your attention.
Thank you. Rachel Bonelli, followed by Vicki Blackburn.
Morning. Right now, while we're here, this CSEB board is hosting a community resource fair, And these folks and organizations that do a lot of good for this county have been characterized as a nefarious organization. But I would like to just let you know what's really going on there. People and organizations represented are like Safe Horizons, NorServe, RISA Early Childhood and RISA Head Start, Port Huron Adult Learning, Michigan Works, Michigan Rehabilitation Services, Avia Credit Union, Choice One Bank, Huntington National Bank, Troy Hospital EMS, the Sheriff's Department, Food Bank of Eastern Michigan, City Hall of Port Huron's Farmers Market, Michigan Department of Health and Human Services, Operation Transformation, Harbor Impact Ministries, Blue Water Community Action, Salvation Army, Kind Humans for Humankind, Secretary of State, United Way, Women's Life, Xfinity, Right to Life, Community First, St. Clair County Health Department, Sparrow Pregnancy Center, MDHHS Environmental Health, YMCA of the Blue Water Area, Detroit Rescue Mission Pathway Shelter, Harbor Street Outreach, Blue Water Habitat for Humanity, Be Warm, Port Huron Housing, Village of Lake Huron Woods, Blue Water Developmental Housing, McLaren of Port Huron, Meadow Lodge, Lakeshore Legal Aid, St. Clair County Front of the Court, Meridian Health, Molina Health, McLaren Health, St. Clair Community Mental Health, St. Clair County Suicide Prevention, Catholic Charities, Port of Hope, Sanborn Gratiot, Ageway, ARC, Blue Water Allies, St. Clair Vets, Detroit VA Medical Center, Camp Grace, Live Big and Loud, Alcoholics Anonymous, Narcotics Anonymous. I mean, I could just go on and on. These are good organizations doing good for this county. This was characterized by Dr. Nevin as a nefarious organization. I don't understand. I just don't understand what is the thinking. Please, please, just think about the community and the good that you should be doing instead of the mud that you're slinging.
This will be really brief. One thing is I would like to request respectfully that immediately the entire board packet start to be published online, as there are people that have access to it ahead of time and most of us do not. I find that to be a real lack of transparency, and it prevents communication from being at the level it could be. Because if I had time, if others had time to prepare, having seen the board packet, we wouldn't be coming up here trying to ad-lib and trying to just talk off the top of our heads. We could be prepared with the facts in the packet and the documentation, and maybe we wouldn't even have to come up here because the questions would be answered in the packet. So that's one thing. The second thing is, I'm, again, going to go on record saying that I have a real issue with boards giving one person, and respectfully, Dr. Nevin, we've talked, and one person should not, in my opinion, have unbridled power in our county, and that's what's being requested time after time. And I think that that's a real problem, especially when that one person is part-time and has indicated that he doesn't want to be as tied to St. Clair County, which I understand. There's solar, there's litigation, all of that. So with that, I just want to thank you for your time. Please do start publishing the board packets immediately as soon as they're out for the rest of you. Thank you very much.
Thank you.
Thank you.
Is there anyone else that wished to address the board? Seeing none, we'll move on. We have the minutes from April 15th. Accept a motion to approve.
Motion to approve?
Is there support? Support. It's been moved and seconded to approve the minutes of April 15th. Is there further discussion? All those in favor, aye?
Aye.
Opposed? Motion carries. Correspondence? None? None. Okay. Unfinished business. Teen health?
Just a quick update for the board.
There has been multiple meetings with community.
Can you guys hear? No. Are the mics on?
Screen.
Okay, now it is. I can hear them now. Go ahead, sorry.
Sure. There has been multiple meetings with Community First leadership and the leadership here at the Health Department, moving forward on a transition plan for our Port Huron Center to move over to Community First. The most recent information that we have that I can share with the board would be that their timeline is, best case scenario, August 1st. And then they said through September 30th. So I think they're shooting for August 1st. That's what we're working towards. But we have left it open a little bit there. Also, my discussions with the state on our contract, we set a date of August 31st to close everything out, but that is adjustable as well if we had to continue on through September with finances and things like that. In detail, things that are being worked out that are complicated that you wouldn't think about are things like security systems, cameras, IT.
Little things.
Little,
that make
they
it
seem
big.
little, but
Yeah.
you need them to run the clinic. The details are what is now being talked about routinely, staffing, the grant, work plans, where we were with projects. So that's where we are.
Thank you. Civics Plus, you're back up.
We do have an update. I am
Yes.
happy to say there's been some great project progress made. Thank you to county administration, and Chris Morris is here to talk a little bit in detail about that.
Perfect.
Thank you, Chris.
So Paul is going to bring it up. Yesterday, I finished a template trial run, and it's based off of our board packets currently. So this will solve the problem of agenda packets because everything is included all in one. So this is what currently I have it set up to look like for the Advisory Board of Health. The logos can be changed out, so we can put the Health Department logo in it. I can add, remove, change categories. And then on the left-hand side of your screen, those are anything that has an attachment. I didn't add them all because it was just a trial, but you'll be able just to click on it and bring up the attachments as well. And in the same, it'll be all in the same place. You can also, minutes can be done from here. So your agendas minutes will all be in one spot, and this is on the public side. It can be linked to the website. So if you want any changes, you can get with Liz and Greg. And I think we're going to meet next week to go over finalized workflows and things of that sort.
Perfect.
Any questions?
So Chris, does that mean we get this instead of our normal packets on a month?
That'll be up to you guys.
I think we'll have to decide that. I don't know how it works at the Board of Commissioners level. If they're printed for you ahead of
No.
time and emailed to you,
No.
they just,
Yeah,
right?
They
So-
just log in?
everything is electronic, yes.
Okay. Yeah, I think there's some internal procedures we need to work through, or how things get posted and approved, if that goes through Monica, and Monica goes through Tammy, on what gets uploaded there, at what time it's available to the public, to you. Those things we can detail out after our meeting with Chris, and I can update you via email.
I
But
just
everything
wanted-
should be ready to go for the next meeting?
Yes, so
Okay.
I only, what I have left to build is like the behind-the-scenes things, the approvals, the workflows, things of that sort. And then anything you want changed, I'll do before I make it like a permanent
Okay.
format.
So these will be available on Friday, like, before the meeting, like they currently are for the public too?
It
All
depends,
of us?
whenever you guys
That's
want your
what-
packets available.
Yeah, I guess that's up to the board, how they want to do that. Again, I'm not sure at the commissioner level how they do that, if it's available to the commissioner on a date and then public a different date. I
Everything
think
gets
it's
published the same
Same
day.
time, okay. So I think it's best just to mimic what goes on countywide, in my opinion.
Okay, thank you.
Thank you so much.
Thank you.
Thank you.
Okay, fluoride regulation, next steps. Who's taking that?
I just wanted to say, I think we left this on here,
Yeah.
waiting for direction from the board on those next steps, a time frame is what, I know, we know the next steps that have to take place, but the time frame, I think we need a little bit of direction on, in my opinion.
So, Madam Chair, I can provide some context. So we have a final draft regulation, which has been submitted, subject to legal review. It is ready for public dissemination. It's ready for publication. And at the health officer's direction, it is ready for public notice and comment, similar to what we had with the solar regulation. One or more set meetings where the public is invited to give a comment that we then consider when determining whether changes are necessary. I believe at the last meeting, there was a comment from our board representative that the sooner the better, as far as having those meetings. From my perspective, there is no particular urgency. The regulations, of course, if they were to go into effect this year, would have no immediate effect because they are contingent upon the EPA completing their review under the Safe Drinking Water Act, which I don't expect will realistically be completed until sometime in 2027. But that being said, we do have a final product. This is of public interest. We have for some time as a board been noting the need for action on this issue, and the draft regulations address that need. So I might suggest, unless there is opposition to the contrary, that we publicize those regulations, that we post them on the website, we post them publicly for inspection, we make copies available for folks who come in requesting a paper copy at the front desk, and that we schedule perhaps over the summertime one or more public meetings to obtain the necessary comment.
Is there comment from the board? Okay. All right.
So I was just looking for clarification on summertime. And if you could just get back with me a little bit more. Does that mean July? Does that mean August? I know Dr. Nevin seems open to any of that, but what works for you as the board? Or do you just want that decision up to us?
The public hearing is going to be, I mean, it has to be Dr. Nevin and you that hold the public hearing.
Right.
So you'll have to schedule it around your schedules. I would assume it's going to be an evening. And then whoever from the board that would like to attend it can be also in attendance.
Okay.
But
So
we
we
would
will
not be
formulate
part of
that
that.
and report it back to you.
Correct.
Okay.
No, it's all good. No crisis. Okay, so you'll get that scheduled then? Okay,
Yes,
perfect. Letter of support for the Moak Street project?
Well, that was just put on there from the
Yeah.
last meeting.
Yeah.
I didn't know if you wanted it to continue on unfinished business or where you were with that, if you need our support. You made a motion, I think?
Yeah, we made a
Yeah.
motion for that. I guess I assume that that letter was just being produced.
Produced by me?
Yeah.
Or you, coming from the board?
Well, but produced by the health department.
Okay. For the advisory board?
Correct.
Yes. Okay.
That was my assumption too, Monica, sorry.
I had a different assumption, so I'm sorry.
Yeah. No,
I
no,
thought
I
you,
didn't clarify
this
that
was a
with you.
letter from the advisory
Yes.
board.
Right.
Supporting the Moak Street project, not necessarily, health department, and
Right.
that's fine, it's from the advisory board, but we can draft something, get it to you, Monica, for your signature. Okay.
All right. Contract updates. We have Tom Hall here.
Thank you for having me today, Board. Just wanted to provide a quick update, similar to what we provided at the Board of Commissioners meeting for the committee. Just continuing to work with the health officer and the medical director regarding contracts, figuring out how we best kind of develop a system that works for the health department, the citizens, to ensure that we're all working in the same direction. So Contracts have been sent over to legal for review. I plan on initiating conversation individually with both the medical director and the health officer for their contracts specifically, so they can review. Really just looking at all the things as directed by the Board of Commissioners. I am planning to have both individual contracts and one that combines into the medical health officer. So just continuing to look at all options, anticipating that this will go to the Board of Commissioners at the June committee meeting, kind of for their decisions. So any questions? Perfect. Thank you.
Thank you.
Thanks, Tom.
Okay, moving on to new business. Dr. Nevin.
Okay, thank you, Madam Chair. So the first item you can see, I've listed Andy's hantavirus update. This topic has been in the news in recent weeks. I almost thought about updating the agenda because now there's a new virus. It's even higher up at the top of people's concerns, the Bundibugyo virus. Technically, it's not the Ebola virus. No, it's the Bundibugyo ortho-Ebola virus, related to the Ebola virus. But perhaps... Yes, Bundibugyo, the Bundibugyo ortho-Ebola virus. But as necessary, as circumstances warrant, I can give you an update on that next month. For the purposes of this meeting, I will give some context. The CDC and the state issued some guidance, and I advised our staff that I did not think that it was appropriate for us as a local health department to issue any particular local guidance on this topic because there isn't a local nexus yet for hantavirus. And I didn't want us to appear to be focusing on something that was not particularly relevant to the health of St. Clair County residents. But that being said, because there is some concern, because this is a novel health threat, I thought I would just make a few comments to reassure folks and then provide the board an opportunity to ask me questions. So the virus at issue is a hantavirus, but it's a particular strain of hantavirus which is somewhat unusual and concerning because unlike all of the hantaviruses, which are exclusively zoonoses and which transmit through aerosolized rat urine mostly, this does have occasional airborne person-to-person spread. It's the Andes strain. And we've known about it since the 1990s. I recall when I was in the military, we talked about this, this virus. It was on our radar screen, but not terribly concerning. The military pandemic planners are far more concerned about influenzas and things like coronaviruses than hantaviruses. This is a well-known virus. This is nothing new. There's nothing novel about this. We've known about this since at least the 1990s. In the Andes region of Argentina, there are approximately 100 cases per year. This is in a population at risk of somewhere on the order of 10 million who live in the immediate area. So you're looking at a risk of 1 in 100,000 for this on a typical basis. About 3,000 cases total, and 90 to 95% of these cases are acquired the usual way through exposure to aerosolized rat droppings or rat urine. It's really only a small percent, 5 to 10%, which are transmitted person to person, right? And this is what's prompted the concern with the recent cluster associated with that cruise ship. Now, unlike most respiratory viruses that are of pandemic concern, that have strong aerosol production and that have strong generation-to-generation transmission, reviewing the literature, the most generations this has passed human to human is 4. So the overwhelming majority of these cases stop, and they don't transmit from person to person over successive generations. By the time you get the flu, or by the time you get varicella, or the time you get measles, it's passed through dozens or hundreds of people, generation after generation. This virus tends to stop. Typically, an infected individual will themselves infect maybe 1 or 2 more. There are occasional super spreaders where you get a dozen or more cases resulting, as with many viruses, but this is unusual. So from an epidemiological perspective, this virus really does not have significant pandemic potential, and I think most epidemiologists in my position and at CDC and at the WHO are not terribly concerned. This is very amenable to the usual armamentarium that epidemiology and public health brings to bear, namely quarantine and isolation. Quarantine, an old practice that dates to the era of the Venetians, literally means 40 days, right? And so the ships that would come in from areas where there was disease, you would quarantine them in the harbor for 40 days to ensure that nobody developed symptoms of whatever was going around. And then after the period of 40 days, the quarantine, then you would let them come ashore. And quarantine works perfectly well to manage whatever minimal risk is posed by this and related viruses. To my knowledge, there are just a handful of individuals associated with the outbreak here in the United States who are being quarantined, either hard quarantine at our national facility in Nebraska or soft form of quarantine at home based on assessment of lesser risk. Very little concern about the potential for secondary spread. If there are secondary cases that develop from these primary exposures, that's okay. We'll track down their exposures and we'll quarantine them, and almost certainly the virus will stop. I would be very surprised if we see even 3 or 4 generations from this virus wherever it has taken hold around the world. And because the maximum time you wait per generation is about 40 days, you can see within 160 days, 4 generations, we will know if anything is different. And so I expect within 160 days from this coming to our attention, we will be able to say, not a problem. Now, I know some folks are concerned because, well, our experience with COVID. But this is very different than COVID. So there is no Andes Institute of Hantavirus Research that has received funding from Anthony Fauci, right? There has been no gain of function research conducted on Andes hantaviruses. In fact, the genetic strain, the genetic code for this virus, it's been sequenced, and it is exactly the same as every other version of this strain that has been circulating in the Andes area for many years. So there is no reason to be concerned in that regard. When I was in the military, I told my neighbors, I said, they knew I was an epidemiologist, they knew I studied pandemics, and they said, well, Dr. Nevin, you know, how do we know when to be worried? And I said, well, if you see my car gone for about a week, and you don't hear from me, then you know to be nervous. Otherwise, you don't have to worry. I am not concerned about this at all. And because I'm not concerned about this at all, because there is no local nexus, because there are no exposures identified here in our area, because there are no cases in the United States, this is just not something that, as a local health department, we really need to spend significant time discussing. And the right place to discuss this, if any, is right here before the Advisory Board of Health, where I can answer any questions that the board may have. So I'm happy to take any questions on this topic. Good. Yeah, this is not a big deal. All right. So now moving on with the other items in our, we're not doing COVID again, by the way, so rest assured. Now moving on to the other topics in the agenda. What you'll see before you is a study proposal. This was put together by our plans department with some input from me. I believe most health departments should aim to publish one scientific study a year. Maybe I'm old-fashioned, but I believe that public health should be motivated by scientific observations, and we should share our scientific observations in the literature for others to be able to benefit from. And so what you see before you is a study proposal. We're working to get this approved through the state. It's titled In-Person Immunization Exemption Education Follow-Up Study. Do children whose parents completed an in-person education encounter subsequently receive the state-required immunizations? And what we're proposing is to study the outcomes of children of parents who have come into the health department in recent years for those vaccine exemption education sessions, the 15 to 30-minute sessions, which per the prior interpretation of the regulation we had believed were necessary prior to moving to a fully online system. And what we hope to be able to comment on is how many of these parents actually had their children's vaccination behavior changed as a result of these supposed education encounters. My null hypothesis is that we don't see much significant completion of vaccine requirements in the aftermath of these encounters. I'd be pleasantly surprised to learn otherwise, but because we actually haven't formally studied it, this study will address that question. And we hope to be able to use this study to confirm the appropriateness of our switch to a fully online system, and also potentially this may help other health departments who are considering adopting a similar policy to our own. And if we can get this data from the state, if we can get this study approved, I expect we can probably submit something for publication later in the year, and then maybe some of our staff members can get their name on a paper, and that will help them out, and you know, it'll show that we are doing good science here. So that's our study proposal. Happy to take any questions on that. Okay. Moving on, we just have two more items. This item is not fully baked. I added an email and some correspondence I received from one of our staff members, because I realized after I wrote the email, I thought, you know, maybe I spoke too quickly. Maybe I should have checked with the Advisory Board of Health. And so this agenda item is added for your consideration and review and comment, just to ensure I'm not completely off track here in what I have advised. So the matter at issue is we have some additional funding. I think we have some extra funding in our harm reduction budget, and the proposal that you see before you in this memo is for the department to purchase some sharps needle disposal boxes to be placed presumably in local parks where I'm told there has been a problem with finding needles where children play. So this is an example of harm reduction. This is an example of a public health approach that essentially ignores the inherent criminality in much of the behavior at issue and focuses on ways of potentially reducing the harm associated with that criminality. Harm reduction, when taken to its logical end, results in things like what we see in San Francisco, where the city health department offers free alcohol distribution sites, provides drug users free crack pipes and needles, and that essentially ignores the criminality associated with that behavior, and often to the detriment of law enforcement's ability to intervene. Opinions on this vary, and there are obviously very strong opinions, one way or another. From my perspective, having studied the evidence in support of this and sensing what I believe are the community's concerns in this regard, as you can see in this email, I said, I think we should not approve the purchase of these bins, and instead, to the extent that this is a problem, refer the problem to law enforcement for aggressive enforcement and prosecution as necessary. There are other aspects of harm reduction which perhaps might be amenable to some action on our part. For example, the distribution of Narcan. I have some concerns with that, but I recognize the value of that. But, for example, doing what my native Toronto does and distribute an iPhone app that allows drug users to order crack pipes for delivery by DoorDash, I think is not something that the residents of our county would support, and I would certainly not support that. What I'm looking for from the board is any comment at this point confirming that I am directionally correct in this email to our staff member, with the understanding that if there's interest from the board in exploring this topic further and exploring our current harm reduction activities, assessing them and making a recommendation for future changes, that I will write up a memo, a detailed memo, as is my habit, in due course, addressing this issue thoroughly and making formal recommendations. But before I do that, I was looking for a general sense from the board that I am not completely off track rejecting this particular suggestion. So I'm happy to receive comment on that now.
Anyone have any comments?
I have a couple questions, actually. So we have money extra, and that's why this proposal was presented, correct?
Yes, I believe so. And it may be due to either potential loss of staff, which may free up some money, or just excess money in an existing grant.
Does that money have a certain time frame to be used?
Yes, yes. So there is some money left over in that budget, and it does have to be used by October 1st or September 30th. When that money comes in every year in our budget, October 1st. It is, I wrote it down, about $95,000. This year, we got an additional $75,000 for any projects. We have not come up with a project to utilize those dollars on, and Dr. Nevin is correct that we have had a staff member resign. So a lot of that fund went to wages, just in general, and when they did the outreach and promotion of the program and other aspects of the harm reduction program that are there. So I'm glad Dr. Nevin brought this up because, if I may, sorry, on his agenda item. But we have, I think for the last year, have talked about the harm reduction program and that we need an overhaul of our harm reduction program. We need to look at it differently. Things are changing. We started the program, I want to say 2016, 2017, 18, not sure, so around there. And it was driven mostly from an infection prevention standpoint, where our hepatitis C numbers were in the 200s annually. Now you can see in your report that we provided you, that number is significantly dropped. I know it's not directly correlated, I'm sure Dr. Nevin would say in his epidemiology mind, you can't say one, A plus B equals C. But what we have seen is a drop in that hepatitis C number, not necessarily related to our syringe exchange program. Also possibly related to drug culture, and we know that the heroin use has decreased within the community, and the drug of choice has switched to meth, which means your health effects and exposures may be different, of a different sort. So the money coming in, where I am with it is, I would like to see us continue to utilize this money in a way that works for St. Clair County and is agreeable to the board, whether that's naloxone, education, promotion, continuing into recovery. We do a lot of work with our recovery partners, things like that, but we do need some kind of overhaul, and I agree, we need some guidance from the board on that.
So my last question, sorry.
Yeah.
I'm not trying to be.
My long rant.
Nope, you're good.
No. Has any other proposal been presented or considered other than this one?
No, I don't think so.
And has there been anything statewide
Oh,
that has been shown to be effective regarding meth or other recovery or anything else going in that direction that we might consider to be copy or something like that?
what I will say, I said no quickly, but what I can share with the board is the overdose fatality review. If you remember, that team started within the last couple of years to review the deaths due to overdose, and they had an annual report that I'll share, and they had recommendations, starting with naloxone. Some things we cannot address, mental health, no longer do we have social workers impacting that. They talk about huffing, miscellaneous things, those things, but I'll share that with the board. And then, I'm sorry, your next question?
Was there anything statewide that may be something we could mimic as far as education, recovery, or something else like that,
Other initiatives that other people are.
Thank you, Monica, for better wording that for me.
Not that I'm aware of. I mean, I guess we can explore that, but to me, Dr. Nevin would be better suited to answer the medical and health impacts of that drug.
This idea came because Tuscola County got grant money to put these collection bins, and through the health department. So we just took a quick glance at that and thought that collecting syringes from even diabetic syringes, anybody who would want to utilize it, we thought we would explore it.
No, and I'm okay with that. I was just like, were there other things presented as well, or was this the only thing presented is where I'm going?
Well, I know there is big discussion about safe smoking devices, but we turned that down right away. That we didn't think that that would go over well in the public to offer, like Dr. Nevin's stating,
Yes, the
safer
crack pipe
devices.
Ubers are not going to be popular. here in
Definitely
St. Clair
not, and
County.
I don't agree with that either. But I think there's a push in some areas to use your funds for safer smoking devices, and we have not pursued that. We knew that that would not work well. And where you can explain the use of a clean syringe from a health perspective in general, I don't know that from a infectious disease perspective, we were gonna win on the pipes.
I wasn't necessarily thinking of that, Liz. When you're looking at vaping, smoking, obviously St. Clair County is very high in that area. Has it been considered some of the other non-medical devices that you, I know my one teenage son is, well, not teenage, he's 20 now, has been using one to quit vaping. It's non-medical, it's purchasable, but has anything like that been considered to give to teens or non-teens or anybody desiring to quit smoking to help the overall general public? Not just overdose, but
Smoking
general
cessation.
smoking cessation in general.
Which could lead to other things, yeah.
Absolutely.
We can look into that. I have not. Or the nursing division is shaking their head, no, they haven't.
Right. So, Madam Chair, harm reduction is a,
State term.
we have to be precise in defining terms. What I think the board would have no concern with, and what many public health departments do, for example, children assist the public in stopping smoking through various legal means. This is not harm reduction, as the term is commonly used. Harm reduction very often implies turning a blind eye to obvious criminality. And in this particular case, as my email makes clear, we are not dealing with, well, I'll read straight from my email. As much as we may like to pretend otherwise, the matter at issue here is almost certainly not diabetics and the obese visiting local parks to carelessly inject their prescribed Ozempic. We know what the problem is. And to the extent that our parks become full of these bins, there are numerous second-order adverse effects that we must consider. There are always second-order effects. Do we as a county want to normalize and tolerate open-air drug use in parks intended for children? By including these bins in parks, we are sending a very clear message that we as a community tolerate the criminal use of narcotics in public with the potential for the discarding of potentially dangerous needles in places where children play. Not everyone returns their shopping cart. Not everyone will place their used needle in these bins. And I believe, based on an analysis of the harm reduction literature and simple common sense, that if we begin to go down this path and embrace these harm reduction strategies, it's only a matter of time before we find ourselves in the situation that every other city that's embraced these measures finds themselves in, right? New York, San Francisco, my native Toronto. This is a failed strategy. And there is a role for law enforcement in public health issues of this kind. And my concern has been law enforcement has long expressed concern with harm reduction. I think that these concerns have been largely silenced because public health has beat it into law enforcement that you have to let us do our job. But public health has failed. Harm reduction has failed. And the consequences have been dire, not only for the individuals involved, but for the communities that have to suffer the second and third order effects from these failed policies. So what I might propose is, if there's general interest in exploring this and coming up with a rational, deliberate strategy for how to approach this issue, that I write a memo where I review the literature, I review the concerns, and I review what we have done. I can get with our staff and review what we've spent our money on and what we've accomplished, and then I can make proposals to the board for consideration. We can do that perhaps in about a month or two. So that's what I would propose to address this.
I have a comment. I'm in greater support of educating. Education, I remember growing up, that commercial, this is your brain on drugs, like with the fried egg, that was impactful. Maybe billboards, maybe, these young teenagers don't know what vapes do to their lungs and their bodies. Maybe harm reduction would be focus on obesity in the childhood, obesity crisis that we have, and this is what you can do to change that. Maybe billboards, maybe that would be more of a harm reduction, because you're doing long-term harm, to the body, and these kids just they've not been educated, maybe very well, or maybe enough. I think there was, people have to hear something X amount of times before they actually get it, or understand it. So maybe switching gears and, providing some education.
We have provided the education, and I'll say just this month, we have 2 education sessions planned. One with Parks and, where's the other one? Harvey Reinvestment Center. So there is requests from the public for education.
Yeah, and is that like inviting voluntary people in, or is that like putting it out there, like a billboard, like, okay, this is, they're always seeing this, maybe, in conjunction with the education session, so it's not so much as voluntary, but it's like always in their face, that this is a harm to your body. And of course, the education, maybe incorporating and looking at, the obesity and healthy diet and, activity and movement to try to help to change that mindset as well.
So, Madam Chair, the memo I will propose writing up will address the definition of harm reduction as it's currently used. I don't think any current use of that term anticipates addressing healthier eating habits. For example, harm reduction is a euphemism, right? It is a term that the community adopted to mask the nature of the activities at issue. For example, providing drug users who are engaging in open-air criminal behavior with needle exchanges, supervising the administration of narcotics and other dangerous drugs. In many cases, protecting the individual from the legal consequences of their behavior with the misguided expectation that this would improve their health, none of which is shown to be true. So harm reduction, the term is a euphemism, which I think is largely unhelpful. The specific matters at issue here relate to public health's condoning and tolerance of illegal, dangerous, antisocial behaviors for the specific benefit of the individual involved, largely neglecting the societal detrimental effects of that. And as a public health strategy, I think the evidence shows it has largely failed. So the memo that I would propose writing up would focus on harm reduction as the euphemism has been commonly used. For example, dirty needle exchanges, open air supervision of drug administration sites, crack pipe Ubers, as in my native Toronto. And the other topics, while worthwhile, these fall outside of harm reduction. Those are worthwhile activities, but we could not justify spending harm reduction money on, for example, a billboard saying, don't eat junk food, because that would not be considered harm reduction by the grantors.
Your brain on drugs, you could, though. I mean, the fried egg, that does go under it. Personally, I thought this was a great idea, in all honesty. And I say that because I get calls at our township office all the time looking for where to get rid of syringes. There's a lot of diabetics. There's a lot of people on GLPs that have these auto injectors that are looking for places. They tell them not to put them in the landfill. That's great, but where are they putting them? In the landfill. And that puts our landfill workers at risk. if they had somewhere in the county to take these, and I think they would have, and I didn't see where it addressed where these were supposed to go. But I thought, to me, if you had them, I don't know that 5 spots is enough in the county personally, but I would like to see one on the west side of the county. But I don't think people that are addicts are going to take their needles to these. I don't think that, because they're not getting anything out of it. For the needle syringe program, the exchange program, I was on the board when that program was instituted, and I think it was in 18, it was before COVID, somewhere in that range. I was initially against the program because I just didn't think that that was a good use of county money, or actually, it was all grant money. But I can see I think what we could see is successes of that program perhaps. But I think that these right here do serve a purpose. These boxes do serve a purpose. And personally, I would support these and would like to see them in the county. Because I think they're, like I said, there's a lot of people looking to get rid of syringes for a lot of different reasons than drug abuse. So
Yeah.
it's a safe way to get rid of syringes.
Well, thank you, Madam Chair. And of course, I'll again refer to my email saying, matter at issue here, particularly with the placement of these
Right.
parks, these bins in parks where there's clearly some illegal open-air drug use. The matter at issue here is not the problem of people discarding their Ozempic needles. There are other ways to address that particular concern, which is not harm reduction, right? Harm reduction as a term relates to minimizing the harm to the individual and their immediate environment from the illegal use of substances, not Ozempic, not diabetic needles. And there's certainly a role for us to address that latter aspect, but that is not harm reduction.
I don't argue that, but if it's allowable under the grant, I think it's an asset for the county. And I don't think they have to go into parks. I think they could go into other places. And, you know, there's a lot of ways to skin a cat.
Madam Chair, what I might propose, given that there is interest in this, given that there's significant interest in this, why don't I write up my thoughts? I'll prepare a detailed memo with some pros and cons and outlining my concerns, given what the literature shows, given the values and priorities of this county, and then we can have a more thorough discussion with that memo before us at a future meeting.
Perfect. Everyone good with that?
Yeah.
Okay, thank you.
Okay, so last item I have, and thank you everyone for your patience. You'll see a memo before you written May 13th titled Proposed Reform of the CHNA and CHIP Process. I apologize, this is a very dense memo, a lot of facts, a lot of footnotes. For the board's edification, when I write these memos, I am writing them for you, I'm writing them for Liz King, but I'm also writing these for my peers, right? I am writing these memos for the State Public Health Department, I'm writing these memos for the licensing board, because it's important for me to demonstrate that as medical director, I am properly considering the matters that I recommend as medical director. And so you can see that this memo is very thoroughly cited, citing significant evidence in support of what I'm recommending here. I didn't include in your packet, but I trust you're all aware of our bylaws, the Advisory Board of Health's bylaws, and I'll just direct the board's attention to Article 2, Paragraph B, the items I through VI, 1 through 6. The Advisory Board of Health shall recommend and review required programs of public health services to at least meet the minimum standards of performance as prescribed by the State Health Department. Specific duties of the Advisory Board of Health shall include, but not be limited to, identifying and recommending priorities of public health problems for community action. This is the board's job. Adopting resolutions setting forth the position of the board on pertinent community health issues and actively promoting and advocating public health policies to the community. This is the board's job. promoting the collaboration and coordination of the department's programs with public and private agencies to maximize effectiveness of public health dollars and provide a network of cooperation in the community. Again, this is the exclusive responsibility of the Advisory Board of Health. Participating in state and local public health organizations, conferences, and seminars is deemed necessary for education and information of members and the Board of Commissioners. So the bylaws adopted by the Board of Commissioners give the Advisory Board of Health, in collaboration with the health officer and the medical director, exclusive control over setting policy direction for the county and determining priority areas of public health concern. This is the board's job. And even if this weren't the board's job, it probably should be, because our meetings are televised, they're recorded. Before we take up an issue, the public has an opportunity to comment on the record. There's full transparency. No more than 4 of you can meet at a time to discuss amongst yourselves in advance what will be talked about publicly at the meeting, unlike private organizations not subject to that restriction. This provides protection to the public. It ensures that decisions that are made regarding how to spend their tax dollars on public health programs, regarding the direction that public health policies take in the county, which can have adverse effects, right? We've seen that from past experience. We were talking about one potential example of that just now. This ensures that there's accountability to the public, that the decisions that we make about the public health direction that the health department will follow is accountable to the voters, to the people of this county. It's the only way that we can ensure that our policies reflect the will of the actual voters and people of this county, and to ensure that these priorities are not captured or directed by special interests, as worthy as their efforts might be. As a public board, as a public health department, as all government agencies, we must be vigilant to ensure that there is no regulatory capture, that the regulatory agency, that the oversight agency is not captured by the special interests that they oversee. And so what this memo proposes is that the Advisory Board of Health reclaim responsibility for its duties under the bylaws, and that we move our formerly contracted process, where we contract out to a private party the setting of policy direction for the health department, that we take that process back into our own hands and deliberate on these critical matters openly in a public forum. And as my memo shows, the way we've been doing things for recent years is neither required by law or regulation. It's decidedly unusual when we examine the actions of health departments across the state, and potentially it is counterproductive and not best serving the actual needs of our county residents as articulated in recent months to 2 years. So what I'm proposing is that we have sufficient in-house expertise. We have myself as medical director, board certified in public health and preventive medicine, and with our staff able to produce any sort of formal reports that might prove helpful in this regard, that through the same process we've been following, where we bring public health concerns or issues of interest to the board for deliberation in open forum, subject to the Freedom of Information Act and Open Meetings Act, that we continue this same approach for our setting of new strategic priorities for the coming years. This issue is coming to your attention now because, quite simply, we can't put this off any longer. I was approached by staff, I believe late last year or early this year, wanting my opinion on contracting out this community health needs assessment process. You're looking at a 5 or 6 figure cost, hiring an outside organization to do this work. And my position at the time, and my position remains, that this is not a good expenditure of public funds. We cannot ask the taxpayer to bear this burden when we have sufficient in-house staff, including myself, who can produce a product of equivalent or superior quality. And as you see in the memo, I have concerns with the product that has resulted from this approach in recent cycles. I don't believe that the product truly reflects the values and priorities and concerns of our county's residents. And I outlined that in the discussion, for example, that none of the issues that we have been discussing, right, the issue of vaccine choice, protecting parental choice and parental autonomy, concerns with health effects of solar, concerns with fluoride, none of these public concerns, which have very real public support, have been identified in previous cycles, right? So the current system is failing to identify the issues that the public is truly concerned about. So what I'd request from the board, if the board is amenable, is a motion in support of these recommendations. This would clarify to the department that it not contract as it had been planning for the CHNA, and that in the coming months, myself, in collaboration with staff, and then with the input of various organizations that were mentioned earlier, that we use this revised process to present new priorities to this board for consideration and ultimate approval. I'd be happy to take any questions on this proposal.
I think I would just comment that I think when you talk about identified problems, it wasn't that any of those issues were not discussed in the process. It was that they weren't in the higher level of identified problem. And that could be due to respondents, that could be due to a lot of different things, I believe, but what came up as the identified areas were based on the surveys. So,
And the timing. It's
Right.
the timing.
Right,
Those
it's
were
a
decided
timing-
before all
exactly.
these came up, so that certainly
Correct.
could be in the future. something
right,
to
if
look
you
at.
were to take that survey, it's dependent upon when you're giving that survey. So what your responses would be, in my opinion. So I just wanted to put that out there.
I have a question. Where were these previous consulting firms that the studies were outsourced to? Where are these consulting firms located, or where are they from? Are they from our area, or?
No.
The last two cycles that I have been directly involved in, so over the last 6 or 7 years, was with VIP Research and Evaluation. That's Dr. Marty Hill, did our last two needs assessment and kind of led that. He is out of, I think, the Chicago area, is that correct? But he has done multiple community health needs assessment. As we asked our partners throughout the state, who is working with you, who are you contracting with? His name came up multiple times, and a lot on the west side of the state, in Ottawa, Allegan County, Lake County. He has done a lot of work in Michigan, not necessarily here in St. Clair County.
That process is directed by an RFP, though. We have to put an RFP out, and a lot of the bidders come in from out of state, a lot of the consulting firms. There's very few in Michigan. There was, the price difference on these with the RFPs were from basically $75,000 to $250,000.
And they submitted surveys, that's what they did? That's how they gathered the information? You said survey?
Well, they do a survey if we hire them, and then they do a survey on our behalf. But when they do the RFP, they're just giving a proposal.
No, I mean, like, at the
Yeah.
actual, once they're
Yeah.
hired. it's
So
like-
what was done last time was probably a year-long process. Greg, interject as you see fit there, but it was probably over a year-long process. Or Brandon Fay, I think, was in on the last round as well. And basically was following the MAP process, right? That is a framework for a community-driven strategic planning tool to come up with a product. It included 4 surveys with key stakeholders, key informants, our underserved population, and then a behavioral risk factor survey with over 1,000 residents done via phone and calling center. Then the data was compiled, analyzed, presented back, and that's that big report you see on the website that's there. And then from our perspective, our next steps were really to present that information and to agencies, to the board, and from there, roll into the CHIP process, I think. There's much more detail
Right.
involved in the framework, but that's, yeah, the overview.
I had a question. Liz, I would be wanting to hear from you right now, support or concerns or just kind of open conversation to get.
Well, I have a lot of questions. I read this over too, and there is a lot of things I think debatable in here, but moving forward, I feel that I agree strongly with Dr. Nevin that we do have the ability to do some of this work in-house. We have, over the last couple of years, really enhanced our data and planning division. I think Brandon, we have Jeremy Berger there, and with Dr. Nevin, who's very willing to look at that. I think we could do the secondary data, which is pulling all that existing information and comparing St. Clair County with the state and with the nation. It's the behavioral risk factor survey part that I guess want to ask Dr. Nevin how we would approach that.
So, Madam Chair, we should clarify, there is no requirement in law or regulation for these two specific products to be created. None whatsoever. All that is required is that the department have a plan of organization that outline how it sets its public health priorities. My belief, as I'm sure you're well familiar with now, is that we refocus our efforts on our core statutory services. Those are hard enough to provide. The very things that the law says you must do. If that's all we did, I think that would largely be enough. But to the extent that we have additional resources, additional time to focus on other priorities, they should be directed by a body that is accountable to the voters. The problem with this process is generally what occurs is that it is captured by special interests. And this occurs when there isn't sufficient engagement by the public officials who are supposed to be responsible for this. And this is what leads to some of the very out-of-touch recommendations that you see enumerated in this memo from prior years. Recommendations for things which the health department has no control or jurisdiction over in the first place. Now, behavioral health was mentioned. We are not a mental health agency. We don't have, at this point, direct oversight over the provision of mental health services. We are not, as a health department, typically expected to be responsible for mental health outcomes. There is a $100 million a year organization headed by a CEO who makes many hundreds of thousands of dollars, who has responsibility in that area. They do not need our help. They have more than sufficient resources to address those issues. Now, to the extent that the health department, in its regulatory and oversight role, believes that perhaps they are failing in this regard, that mental health outcomes are insufficient, that this is a public health problem that we need to address and have oversight over, I would certainly welcome that suggestion, but we would first have to have regulatory oversight of that process. We don't. And so this product, to the extent that this is outside of our immediate current jurisdiction, there's no need for it to focus on mental health outcomes in particular, because what control do we have as a health department over mental health outcomes? We don't provide mental health counseling. We generally don't engage in activities that are strongly effective in preventing mental health outcomes, right? The Public Health Code tells us what we are supposed to focus on: control of communicable diseases, control of environmental health hazards, right? Protection of particularly vulnerable population groups. We are quite busy doing all of those things. So to the extent that there's interest in us taking over responsibility for mental health, I would certainly welcome that. But that has not been a decision that the board has made. It's not been a decision that the Board of Commissioners, through approval of regulations or the health department, has made. The CHNA and CHIP processes that currently occur largely occur disconnected from any of the recommendations or wishes of this board, and they occur largely outside of what I, as medical director, would myself recommend. It's a separate process, which largely benefits the groups involved. Now, if they need a process to benefit their activities, then we can engage in a discussion with them whether we are the correct body to enable that. But we've heard from outside organizations that they have plenty of meetings, they have plenty of resources, they ask the county for money. They should, in theory, be able to do this themselves, right? And to the extent that we are focusing on these activities at the expense of focusing on our core activities, then I think the process ultimately suffers. The fundamental problem here is there's a disconnect between the Advisory Board of Health's responsibilities and what the public is saying they want through their elected representatives appointed to the Health Advisory Board. There's a disconnect between the body that is, in law, accountable for setting health policy in the county and what this largely self-appointed, self-selected, unaccountable group of individuals who are doing good work in their own way, but who do not have that same level of accountability and transparency that we have. There's a disconnect between these bodies. And what this proposal is proposing, is recommending, is that we resolve this discrepancy, that we resolve this disconnect, and that the Advisory Board of Health assume primary responsibility for things which, due to inaction, largely, on the part of the board in recent years, has been largely taken over by outside interests. And it's not clear to me that the public is best served by this current arrangement. I think it's important that we regain control and authority and direction for these matters, because ultimately, this is something that the public entrusts to us to oversee. And in its current form, we are not able to effectively oversee it.
Couple of points on that. You are correct, I know, of course, that we do not have to do a community health needs assessment. We do not have to do a community health improvement plan. There is no requirement anywhere that is a requirement, Monica probably knows, of national accreditation. So it is a gold standard. We never applied for national accreditation. We were not interested. I haven't even approached it with this board, I assume. That stance is that we do not want to pay an accrediting body to come in and tell us we are following all the things that we would get nationally accredited if we did the work to do it. But you also have to pay a fee to be nationally accredited, and we looked at that and said we don't see the benefit that comes out of that. However, there were ideas within national accreditation that we liked that were gold standards for health department, and this was one of them. So again, up to the board to decide if we do that. Again, couple other comments I wrote down. It is a community-driven plan. That is the difference. It isn't a health department-only plan, and what I've said is my votes were not chosen as a health department employee and a public health, servant. I was disappointed that they didn't pick the things that we would have chosen as a health department, but overwhelmingly what they said was, we are concerned, when we look at the data from the Community Health Needs Assessment, we are concerned most about substance use, mental health, and obesity, and initiatives that lead to obesity, like nutrition, those kind of things. And I had to take a step back because we really were the conveners of this. We brought the data there, we convened the group, we lead the group, we put it all together, but it is driven in part by the public. I agree with Dr. Nevin that board enhancing your opinions on that is a great idea. We did offer the survey information. I wasn't on this position at that time, but I'm assuming the board was informed and had votes and the ability to sway that vote, how they would see it. So I agree with Dr. Nevin. Well, I'm not sure. if he's saying not to do this at all. I would like to see us do these initiatives. I think they're good. I think they're good for the community. However, I agree that enhancement from the board would be welcomed. Also, on the CHIP, our administrator is there. Carrie Hepting, before Tom was there, Tom has been at meetings. So also Board of Commissioners are on the meetings. Monica's been on our meetings as well that are there. So anybody can come into those. And I think what we're saying is we probably need more board support to change maybe the direction.
So,
Go ahead. I'm
so, no, I just wanted to ask, like, how has the data in the past years been really received in, in regards to the public? Does the public really find this of value, the data that is collected? Because this is, reading through this is a lot of money and a lot of data that is brought forth to make a report like this. The other thing, too, that I wanted to potentially ask or maybe potentially put out there is, could we do a hybrid model? This board should have a say. We should listen to the public. We all should have a collaborative effort in this. So could a hybrid model potentially allow all of those criteria to be met? And then lastly, we'll go back, or I will ask the question in regards to funding and so on and so forth, how all this kind of comes about in regards to that. Because, this data serves a good purpose. I understand it is costly. I understand there are a lot of people, certain checks and balances within this, but I also think too, we do have, yes, a role as a advisory board. I think to your point, there are things that we should say, hey, if we're gonna put this out for a bid, this is our community, we should look at this. And maybe those will take that under advisement. I'm not really too sure on how all that would work, but I don't know. Those are just my thoughts on that.
To your first point about the data, I'm going to tag in Brandon, sorry. That's why I have the staff here. When things get in depth, and maybe he knows best probably the data being used, how it's used, how the public sees that.
Yeah.
Okay. Brandon, use the microphone so you're recorded.
Thank you.
I definitely can't hear you.
My understanding with the data is it gets pretty widely used. A lot of times it's cited in different applications for different organizations, either applying for grants or funding, or even for private businesses, like when they're looking to match their services to the needs of the community. So I don't have a lot of specific numbers because, we put that out there on our website, it's widely
Sure.
available. We don't, require someone to make a request for it. But just over the last few years, I hear it mentioned a lot when talking about data. And it's definitely saved us some time as well, because organizations and individuals can go to that data versus making like a direct request of the health department. But that said, the last time that this was conducted was, I believe, 2021, so it is getting a little bit.
So do you have the ability in your department to do the data collection?
It just depends, and this kind of goes towards that kind of hybrid model, because the last CHNA we did was really 4 different parts, so stakeholder survey, key informants, a underserved residents kind of survey, and then a BRFIS, so a behavioral risk factor survey. That's by far the most expensive and time-consuming part, because this is something that the same methodology is used by the state and the federal government. It's a lot of phone interviews, and that takes a lot of time and a lot of effort, and that's why historically we've contracted it out. So, but we can do there's many other options for how to conduct community health needs assessment. assessment of secondary data sources. We can do some limited primary data collection. We do have some internal tools that we can use and adapt to collect, data, basically depending on, what direction we receive.
I'll add in, like, we were all in on the last cycle because we were in the middle of a pandemic. And we were like, here, we know it's time, it needs to get done, the data collection needs to happen. We were on a good roll with the previous one. We used the same contractor, and so Brandon did not have the ability to do all that data collection at that time because we had him working on COVID data and other things, and he was being displaced other places. So we're in definitely a different situation now. There also was funds available at that time to use for a contractor, and I think we should be a little more conservative with that now. Although there are some funds budgeted for that, I don't think it's in the world of six figures.
Kind of piggybacking on that, Brandon, can you use mostly your youth behavioral risk assessments or your behavioral risk assessments to get many of that CHIP data already done?
We do, yes, and even like the current, or the last community health needs assessment, you'll notice there's a lot of secondary data sources. So we would definitely use that. I think, we hear time and time again how important that youth perspective and those youth, public health concerns are. So we would absolutely use that.
Did we tie the MiFi into this last one?
We did.
We did, okay.
So, Madam Chair, Brandon and I, we discussed this at length. Remind me, Brandon, was it late last year or was it early this year? We discussed the
I
proposal.
believe it was late last year.
No. Yeah, so we've been putting a decision off on this for many months. So we need to decide which way to proceed. But, Brandon, you'll recall, I expressed to Brandon my concerns with this process. This process is a lot of busy work that is a really good moneymaker for some outside consulting firms who produce big, thick reports full of numbers and make it look really important. But the problem is, much of the data that's collected in this process suffers from being fundamentally invalid or unreliable. When we call people on the phone and we ask them a series of questions that we have decided in advance, we all know that the people that answer that phone are not necessarily reflective of the population of this county. Then when you try to make up for gaps in that data by talking to key informants, what you're essentially doing is you're asking the special interests what they want. And not surprisingly, the data that results just happens to meet the needs and serve the interests of the special interests that have been relying on this report for their operation. Now, whether we as a health department should be facilitating the actions of outside groups, this is a matter that we can discuss. Presumably there are some groups whose goals are aligned with what the public wants and are aligned with the preferences of this board, but there may be some nonprofit and private groups who have been using our data and to whom we have apparently been customizing the work that we do to benefit, whose work might not best align with the priorities of the residents of this county. And the only way we can determine what those priorities are and how we should proceed is in an open, accountable forum, subject to public comment, on the record, subject to the Open Meetings Act, subject to the FOIA. None of these protections apply during the collection of this data. And so what results is a product that from an epidemiological and public health perspective is not particularly useful to me as a medical director, as an epidemiologist, as someone working for the department, largely benefits these outside groups, not coincidentally, and which imposes upon us priorities which were not vetted for public support. We don't need to call people in this county and ask them, hey, what are your opinions on A, B, and C? We know what the opinions of the public is. For example, 95% of residents of this county voted with their feet and decided not to get this year's coronavirus vaccine, even though every single public health official in the state besides me is saying you should get this. What does that indicate? It indicates a profound gulf, a gap, between what public health officials are saying you should do and what the public wants. Where is this discrepancy anywhere in this report? The profound loss of trust in public health officials. That's not reflected anywhere in this report. There are numerous examples of obvious data points, big red flashing lights, obvious data that should be guiding us as a public health department, that we don't need to conduct 1,000 phone interviews to identify, that should be informing our priorities. But we neglect those obvious red flashing lights in favor of a process which produces invalid, unreliable data, largely to benefit the key stakeholders which have captured this process for their own needs. And the people that pay are the taxpayers that are paying $100,000 plus for this and who have to bear the burden of the health department continuing to support programs which don't necessarily reflect what the public wants. So as far as data collection goes, as far as our producing a hybrid product, right, that incorporates some data collection and some feedback from these agencies, this is actually what I'm proposing in this memo. We can produce similar documents. It's not necessary, right? So we may not necessarily, under my recommendation, we may not necessarily call it a CHNA. We may not participate in a process consistent with what others call the chip. But what I'm proposing is that we internally take control over setting broad policy direction for the department, identifying appropriate data, not necessarily actively collecting it, but looking for those obvious red flags and flashing red lights that exist, data which has been ignored for years, and then proposing policy priorities for the county to identify this neglected data. We can produce a document outlining key findings. We can produce a document outlining key priorities. I would suggest that this could probably be best simply incorporated into our recurrent plan of organization, which we submit to the state without going through the formal process of producing these separate documents. And as I note in my memo, to the extent that outside groups, the body that does not exist, led by CMH that calls itself the CSCB, which is largely directing these activities, I have never once been invited to attend any of their meetings. As medical director, I've never once been invited to attend any of these CHIP meetings. I've never once been invited to attend any of the subcommittee meetings. And so I have nothing to report back to this body that has actual legal authority for these matters. What I'm proposing is that to secure their input, to ensure that I am aware of their input and their preferences and what they would like, so that I can report it back faithfully to this board and incorporate it into my recommendations, that rather than many of our junior staff who have been attending these meetings, who don't provide me with any sort of meaningful feedback from the process, that I attend these meetings. And I'd be happy to attend with one or more members of the Advisory Board of Health as well, but there should be a way to close this loop, right? There should be a way for us, as the Health Advisory Board, Health Officer, and Medical Director, to receive comment from these key informants and then feed that back to the board. And I would suggest this would meet your suggestion of a hybrid model, because it would result in ultimately much of the same product.
So just to clarify, what this memorandum is suggesting that we do is just, this will close out December 2026. You will attend the remaining meetings through the end of the year so you can report back to the advisory board. And then we'll decide at some future point what our hybrid model, if that's what we choose to do, would look like. So this isn't necessarily, we wouldn't be saying, okay, let's pass the memorandum, let's accept this hybrid model. We still have time to discuss the hybrid model that we wish to see. We're just taking back what we feel we can do interdepartmentally.
Yes, Madam Chair, that's exactly right. We are overdue on a decision do we commit $100,000 plus of taxpayer money to produce a report that experience has shown hasn't really benefited the health department? It's benefited other groups, but it hasn't really benefited the health department. And it's created this tension between what the legal statutory responsibilities of this board are and what is actually happening in practice. So what I'm proposing is merely support in principle for this change. It would be clear to the health officer, it would be clear to the department that we're not going to be spending this money engaging contractors, as we've been doing at great expense for many years, and that as medical director, as the individual who's on this board presenting ideas, formulating policy for the board to consider, that I be recognized as having some role in interacting with these outside agencies. For 3 years that I've been here, I've never once received any minutes, any updates, any invitation. No one has called me. The medical director has been completely locked out of this process, and so has the advisory board. What this proposed motion is doing is saying, this is our job, and we are going to take back responsibility for it. And then in the coming months, what I propose is, just as I've been doing, I'm going to be writing a series of memos outlining my ideas for general areas of direction, supported by data, soliciting feedback, open to public comment, on the record, subject to FOIA, subject to the Open Meetings Act, with full transparency, and the board can direct further investigation and research as you choose.
I'll be real short. But like he was saying, I think the questions that are put out, you get predetermined results, and you see that with a lot of questions that have been asked. You're going to get the answers you want. It's already going to, whatever you answer, they've already got the questions directed to where they're going to get the desired results prior to, like climate change, I'll bring that up, or scientists, whatever. They do things with already predetermined results because they're getting paid substantial amount of money to get those results. And I think what he's suggesting, and it doesn't have to be an expansive, is what the results you're getting, but you can actually get questions that are correct data for the St. Clair County Health Department. So you're spending money actually on the residents and not on a predetermined that's going to happen. And I did get corrected at one of the meetings in regards to Lisa Beeden, who serves on that board. And she is the chair, and apparently I was the alternate, but I was never aware of that. She never contacted me to make a meeting that she could not attend. And in the process, I talked with Steve Samasco, and now Carrie Angie is now going to be the alternate. So she's going to be attending those meetings, and that was mutually agreed upon. Steve did ask me, and I think that's going to be a great idea that we do have representation. So I did ask Deb Johnson to forward information to all the county commissioners. At this point, I have not received it, but I asked for the attendance for the last 4 years from county commissioner to go to those meetings. So we got representation, because we're giving money there also, to get some type of report from the CSCB. And in 4 years, Lisa Beeden has attended 3 meetings, and we don't have any input. And I've just learned this, within the last probably 4 to 5 months. I didn't even know CSCB existed. So I haven't been, so that's on my fault for not being as the alternate and attending meetings, but I wasn't aware that we weren't having attendance. So I think what we need to do is spend our money to get direct information that represents St. Clair County residents rather than an outside entity giving you because you guys get all kinds of stuff just like we get. It's a bunch of stuff that we get is pretty useless, but we still get the reports. So I think your efforts would be better if you do it. They might have great things with CSCB that they do a benefit, and you can work with them. And I'm going to be talking with administration. I don't know at what point the legal authority where this community mental health, because they are 100% financially on the spreadsheet of a community mental health. They take care of all the finances, all the employment, all the expenses, all the revenues. And I'm not sure that we have a legal authority to even do that. So I'm going to be asking Gary Fletcher that. He did answer my question in regards to the Open Meetings Act and FOIA. They are not bound by that. So I think transparency, when that kind of money is being spent, and representation, and I did ask one of the millions of dollars in grants are going to this. But when I ask, can I get specifics on the $1 million, what that money is being spent for, they don't have to report to the county. Whether it's for administration or it's actually doing great use for the county, I can't get that information. So the grants that are being issued and they draft letters, the own board get to draft their own letters to support grants that they get to receive and spend money on, and I can't get an answer on what that money is being spent for. Millions and millions of taxpayer dollars. So back to this, I think you'll be, in my opinion also, is that you'll be better served if you spend your revenues to get answers that you can better serve St. Clair County residents. I guess that's enough. I rattled enough.
I guess that is my, my bigger concern with this is that we continue the CHNA, whether it's a hybrid version of that, whether we do that in-house, but I don't think that we should just abandon it completely. I think it does serve a useful purpose, and the CSCB aside, right, that really has no bearing on this for us. That's something that's completely different. A lot of those groups do use the data, right? There's no doubt about that, but we also use data from other agencies and other areas. So, yeah.
I'd like to ask too, because, yeah, Brandon, thank you for wherever you're sitting, yeah. I mean, the data,
Moved.
yeah, the data is very important, and obviously it has been done. I would like to ask you though, Liz, I mean, do you want to be you should be involved in this as well? Because
Absolutely.
you are, right?
Yes,
Yeah,
yes,
mean,
I am.
Obviously, there are,
Yeah.
obviously,
Yes,
there are
I should.
things, so.
Thank you.
You know, well, I'm just saying, I think you also bring another perspective, things that weren't on the
Yeah,
report
it's something we
from
need to
before.
work on together.
Yeah, something collaborative,
And
right.
I think we're agreeable to be collaborative on that.
Okay.
yes.
Yeah, I mean, I would support a hybrid model myself for this, because Monica, I agree with you. I don't think throwing everything away is the right thing. We need something where we can work in, like Dave, like you said, what is best for our county? This is our residents, you know, we're all here. That's what we should do. That's my thoughts.
Greg, financially, what do we have allotted for this?
Nothing.
Okay. Well, yeah, I mean, that's, yeah.
No,
That's
So it's
really
not in the
is-
budget.
Yeah, I mean.
well, it's
we
fluid. We didn't
Right.
specifically budget for like a hybrid model for staff time involved, but there is money available to do it. It wouldn't be a financial burden.
Okay. I mean, because
Well,
we
the-
were going to hire,
Well,
if
the
we
past
kept to
ones-
this model, we were going to hire a consulting agency.
Well, previously, if I could interject, we did have approval through the opioid oversight committee to use dollars out of the opioid funds to do the CHNA. So there was approval, and that's what started the process of putting out an RFP. The county put out an RFP for people to do the CHNA. And that's when Brandon brought those proposals to Dr. Nevin to say, you know, where are we going in this direction? So there is potentially dollars going back to the opioid oversight committee, because a lot of the questions, you know, are helpful to them in their groups also. So potentially there's some dollars there, and yeah, we have funds we can move around. It's a priority.
The past one was paid by a specific grant, so we wouldn't have just took it out of, we probably would have still have done something, but it would have been probably out of our general fund instead of that grant. So we didn't, it was either, you know, it was a grant that we applied for, you either spend the money or you don't get the money. It's just-
Right.
So that's how the last one got paid.
Okay.
So, Madam Chair, if I could just add a few words of context. So I did an analysis of the 45 local health departments and their process for setting priorities. We are the only health department that fully contracts this out to outside commercial interests. Many health departments do this fully in-house under the direction of their epidemiologist and their data team. As you can see, I, as medical director, working part-time, I'm more than capable of writing a very detailed, researched, cited, 10-page document. I would propose that with existing resources, existing staff, existing scheduled time, we can produce the equivalent of a CHNA-like document. I would oppose calling it that, because I don't believe that we should necessarily validate this process. It's not statutorily required for Michigan Public Health Departments. And as the health officer said, this is only a requirement if we were to seek national accreditation, which we can discuss at some point in the future. What is required is a plan of organization with a strategic plan and a documented method for setting priorities, ideally based on data and then articulating progress towards those goals. So that is the document that I would propose we create internally with existing resources without the expenditure of additional funds.
With that being said, I would like to make a motion to not commission a CHNA or CHIP with an outside agency and proceed through negotiations in-house for hybrid models to obtain needed public health needs priorities for St. Clair County.
I second that motion.
Does that cover everything?
Can you forward that language to Tammy, please?
Yes. I can forward that to you, Jeremy. That is a very long statement.
Well, and Madam Chair, the advantage of our having open meetings that are recorded is that transcription can be produced like that.
Yeah,
So
absolutely.
it's
I
on
can
the record.
repeat that if you want, Tammy. Do you want me to repeat it? Okay.
I actually would like you to repeat it.
Okay. The motion I made was I'd like to make a motion to not commission a CHNA or CHIP with an outside agency and proceed through negotiations for hybrid models to obtain needed public health needs priorities for St. Clair County.
Madam Chair, if I could ask for a clarification, what does the member suggest constitute these negotiations?
I have not determined that. That would be up for negotiation for the
Maybe
next.
discussion, maybe.
Discussion, through discussions. How, would that be better?
So Madam Chair, one of the items in the proposed motion that I provided you, I did mention that I thought it would be helpful to ensure that we continue to gather the input of the various outside organizations that I attend. I'd be happy to have an appointed member or two from the Health Advisory Board also attend with me the various meetings that are being held and will be held, both as part of the legacy CHIP process and as part of ongoing CSCB-like groups to ensure that they have an opportunity to feed input to us and back to the full board. Is that what the member intended through that language?
Yes, whether that be you, Liz, or
Right. So are you
together.
asking to be the primary member on every CSCB steering committee and subcommittee that we, or initiative, and not have our staff attend? I just need that
I was
clarified.
not
I'm sorry.
considering Dr. Nevin only, I was considering hybrid.
In
through-
addition.
In addition to everything that is currently
Exists.
looking at. So that it could be discussed through the board as we proceed, was my intent.
Yeah, Madam Chair, the issue which I mentioned before, and I'll reiterate, is that over my 3 years as medical director, with statutory and regulatory responsibility for advising the health officer on matters of medical specialty judgment, which in this case are public health policy, in my statutory role with oversight, providing that input, I have never once been invited to any of these meetings. No one thought it prudent for the medical director to be involved. And perhaps this is because previously Dr. Gilmer, who was the medical health officer, Dr. Mercantant, either vice-chaired or attended many of these meetings, and perhaps it was felt that the health officer's substitution for her was adequate. But the issue here is that I am increasingly recognized as having an important role in providing input into public health policy setting. And so by having been excluded from this process, I am not able to provide any commentary to the board on what has been discussed, nor am I able to formulate ideas based on what is discussed at these meetings. So to make up for lost time, and there's significant lost time, what I'm proposing is that it's understood that there's an important role for the medical director in his public policy position to attend these meetings so that I can hear from these groups what it is they might want from us. And in due course, I may have an individual delegated to me that can attend. If staff are to attend these meetings, at the very least, I require some form of feedback, minutes, detailed minutes, and the ability for me to feed forward information to the group. As I've mentioned, I'm completely locked out of this process. I've never once received any sort of back brief or discussion of what takes place at these groups. In general, our junior staff should not be the representatives at these groups because they do not set policy for the department. If they are attending at the behest of management, of a senior official, that's fine. But to the extent that they are attending in that capacity there, they have not been representing me, and they have not been feeding back information to this board. So to make up for that, and in order for me to fully understand what is taking place at these meetings and what these groups are discussing and what they believe is important, because we've heard many public comments, they believe this is important. In order for me to be fully briefed on this, I believe I need to attend many of these meetings going forward. And I've been reluctant to inject myself into this process absent a formal recommendation by this board.
Could that be a different motion?
Are you specifically referring to CSCB?
Well, CSCB is a somewhat nebulous concept, right? Because it doesn't exist, right? There's a CMH-led organization. It doesn't technically exist, right? If someone were to trip and fall at a meeting of the CSCB, they wouldn't be able to sue CSCB. They would sue CMH, right? Because they're the ones administering the meeting. But that's perhaps not germane to what we're discussing. In addition to the various meetings, and Madam Chair, I believe the health officer mentioned the opioid subgroup, which is, if I'm not mistaken, a subgroup of the CSCB itself.
No, it is
No, it's not?
No, it's not. There is a, see, that's how, it is very complex and confusing. There is a substance use treatment, prevention, and recovery subgroup in which I think Brandon, Elise, I have been a representative when I was nursing director, that you could attend. Certainly, I know you're welcome to attend any of those. What I was referring to is the county group on opioid dollars and settlement dollars that have come into the county, and I'm certain Tom Hull would invite you to those meetings. They are kind of suspended at the time, but just knowing, Dr. Nevin, that you want to be more involved, you have the opportunities to be involved if your time allows. And I, as director over that staff who do attend, we will assure that you are informed. If you let us know what meetings you want to report on, perhaps we do that during our admin meetings once a month. We'll formulate a way for you to be updated or that you do attend.
Well, thank you, Madam Chair. So the issue is fundamentally the disconnect, right? Because at all of these meetings, our junior staff who do not set policy, do not speak for the department unless they are communicating positions of the health officer or medical director. At these meetings, decisions are being made regarding priorities for health policy in this county, which directly conflicts with the statutory responsibilities of this board. It is this board's responsibility to do all of those things, identify and recommend priorities of public health problems for community action, adopting resolutions setting forth the position of the board on pertinent community health issues, and actively promoting and advocating public health policies to the communities, promoting collaboration and coordination of the department's programs with public and private agencies. Without feedback between this board and myself and these groups, we are not able to fulfill our statutory and regulatory responsibilities under these bylaws. So what I'm proposing is, given the detail with which I have provided input to this board in the form of written memoranda, which are open for public inspection, given how this has worked, right? I think the most prudent way to address this and ensure that this board receive feedback from these groups is for me to primarily attend these meetings. And if there are so many meetings of these groups that I, in my part-time capacity, cannot attend, then that's a separate problem, right? These meetings are typically quarterly, and it should be feasible for myself and potentially one or two other members of this advisory board to attend all of these meetings, to close that loop and ensure that the appropriate feedback is being provided.
I think that would be an appropriate other,
That'd be a secondary
Can we address the
motion.
motion? Yeah.
Yeah.
Can we address this motion?
Yeah, so. Point of order then on the motion on the table.
Okay. Leanne, could you please repeat your motion? Okay. Thank you.
You're welcome. I make a motion to not commission a CHNA or a CHIP with an outside agency and to proceed through negotiations or discussions for hybrid models to obtain needed public health needs priorities for St. Clair County.
Is there any further discussion on that?
Does the motion need to include the board, the health officer, and medical director, or no?
I can include that for negotiations for the board, health officer, and medical director through negotiations, including medical director, health officer, and the board for hybrid models.
Okay, thank you.
I accept that.
I'll make an amended motion.
Amended.
Yes.
So you take that as a friend, no, Dawn supported it.
I
So do
support
you-
that amendment to the motion.
Okay, so you want to do it through a formal amendment, not a friendly amendment? Is that what you're telling me?
I'm sorry, yeah.
Doesn't it have to be because it's already supported initially?
Okay, we can do it that way.
Formal then? Please and thank you.
So Paul, you made that motion. And Carolyn, you supported that motion to add through the board, health officer, or medical director.
And medical director.
Okay, so is there any further discussion just on that verbiage of board, health officer, and medical director? Okay, so that's all that we're voting on right now is that verbiage, to include that verbiage in the motion. All those in favor?
Aye.
Aye.
Opposed? Okay, so now as the amended motion stands, is there further discussion on that? Okay. So all those in favor of the motion as amended signify by saying aye.
Aye.
Opposed? Okay, that motion carries. So we will not commission an outside agency.
And then I would like to put forth a motion advising our medical director to attend the meetings of the community and finish up this CHIP through the end of the year, CHIP and
CHNA and CH.
yeah. So that he can be included in the meetings. We can direct him, but we can't tell them to include him, right? Like, we can direct him to attend.
So,
That's all really we can do.
well, actually, we can't even direct Dr. Nevin because we don't have oversight over him, but, by contract. But those
Or
meetings
advise.
are all open to, I mean, when Deb was here, she said, you're welcome to come.
That's correct, Madam Chair, but it would be helpful, I think, for this a motion or something similar, to communicate to the outside agencies that I have the support of the advisory board in this role. I think that would prove very helpful.
So what's your motion?
Well, I guess I would motion to communicate to these organizations that we would like our medical director to be included in the community meetings on our behalf. Would that be appropriate?
Madam Chair, one possibility, and again, this is entirely up to the member to propose, but I would welcome a motion to recommend that the medical director and potentially one or two members of the advisory board, as the board may see fit, to attend future meetings of CSCB, all CSCB subgroups, and remaining meetings of the CHIP in order to ensure that the groups have the opportunity to communicate directly with me and through me, the board, their concerns as we continue in this process internally into the future.
I would accept that as our motion.
Is there support? Is there discussion? I guess I just don't see the need for this motion personally, just for the fact that these the CHIP is a public meeting. The CSCB has said that they're open to visitors. I'm not sure why we need.
Madam Chair,
to direct
again, I think it would clearly communicate that this board feels it's important for the medical director to have input into this process, and also communicate to these groups that we welcome their input through the medical director back to the board.
Okay. Anybody else? Okay, seeing none, all those in favor?
Aye.
Aye.
Opposed would be me. That motion carries. Okay. Is that it for you, Dr. Nevin?
Yes, thank you very much for everyone's forbearance and patience.
Liz, health officer report.
Just a few things to update you on, in addition to the reports that you received in writing. Just an update, we have a WIC ME, it's called, that's the management evaluation, and that is their, for lack of a better term, accreditation. In the WIC department, that's scheduled June 8th through the 12th. I'd like to send the tool out so that the advisory board does see the objectives that the WIC department must meet. So I will share that just in an email. And then additionally, an update, November 2026. So looking into this fall, I believe it is the 16th through, around the 15th or 16th? 16th. 15th is a Sunday, opening day. I know it's opening day because I've heard it from the staff.
And what is it? What's happening now?
Accreditation, yes.
Oh, for us.
Accreditation on our core program. So that is Cycle 9 accreditation. Will be happening that week. We did a Cycle 8 accreditation 3 years ago, and that was kind of a light version. That was basically technical assistance. That was not an accreditation I had seen previously. The state, due to the pandemic, really lightened up on their, I don't think there was any not mets being marked. They used it as an opportunity to educate. There was so many new staff, so much turnover at health departments that it was just kind of a lightened version. This Cycle 9, we will go back to the original way that accreditation is done, where there will be indicators that are met, not met, or met with conditions. And if you are met with conditions or not met, of course, there are work plans involved in that. I'm looking closely at recruitment and retention over the past 2 years. I focused on that, I would say, a year ago. We had a subcommittee. We focused on retaining our staff who are here, and we've struggled with that over the past 2 to 3 years. So looking to get that team back together again. Financially, still looking and watching state budget, federal budgets coming out. And then I have a goal to present our proposed budget to this board, just for knowledge, in July, and have some time with you at this meeting to do that. And I think it's important to elaborate a little bit on finances and how they work. We get a lot of questions, not just from the public, but from board members or board of commissioners who come in, and our finances are complex, right?
Yes.
I look at Jeff and he's smirking. Yes, that's a nice way to put it.
Yes, they are.
Yes, yeah, it is very complicated, and I think just an overview would be helpful to the board. Also, coming up, I do want to speak a little bit in June about kindergarten oral health assessment and get the board's opinion. I will present what has been done within the last year with Smiles on Wheels. We did that contract last fall. We renewed that contract, and we would look to renew that again in fall if the board would be favorable. Or do you want to go a different direction? I just want to put out the reminder that that is something we do have to do, but how we do it is decided amongst us as well. There are multiple models. Smiles on Wheels does a lot throughout the state, but also there are other health departments who do employ a dental professional to do this and on a part-time or temporary basis. So could be something to do, look into, and I'm looking for direction from the board. Okay. That's it for me.
Any
Unless there's
questions for Liz? Just on the division summary report, Steve's not here, but maybe somebody can answer this.
Maybe.
The mosquito surveillance and tick surveillance.
Yes?
So how do you guys decide where you're going to survey?
That's a good.
Because these are always on the east side of the county, it seems like, and the west side of the county has a lot of ticks, too. I'm just wondering if our ticks are different than your ticks.
No, nope, not at all. I guess I defer to Greg, because he was the environmental health director. If you have any guidance on that, if not, we can direct it to
I don't
Steve.
know how those are selected. I really don't. Steve would have to answer that one.
Okay,
I didn't
that's
run
fine.
that program.
That's fine. I just noticed that, I would think that these are considered high number of ticks.
Madam Chair, so the public health utility of a drag or a collection will naturally depend upon the concentration of exposure at that area, right? It wouldn't make any sense for us to do a lot of collection in an area where there aren't a lot of people. Whereas
Right.
if there's a very well-attended park or beach, there would be more public health impact to collecting data there. I don't know for certain
Yeah.
whether that type of thinking has informed the choice of site selection. But if I were choosing the sites, I would consider population density and activity.
Okay, that would make sense then. I just note for last year, our Lyme disease numbers were significantly higher, and we've already have 2 cases this year, so we're just barely getting into the season, so.
Yeah, Madam Chair, case counts for things like that vary significantly depending on how aggressive surveillance is. So what you tend to see is some sort of ebbing and flowing of the total numbers. The numbers, in general, the numbers of reportable conditions that are reported can either reflect the true number, and so an increase might represent a true increase, or, and we always have to be on the alert for this, an increase or a decrease might represent changes in ascertainment, more aggressive case finding, conducting more testing, public awareness campaigns that raise awareness resulting in more diagnoses. And unfortunately, in a small county like ours, when you see year-to-year changes in any of these reportable diseases, it's often very difficult to exclude bias of that nature as the actual explanation for the change in count or rate. Certainly our hepatitis C counts in recent years have largely reflected biased ascertainment, not true changes in underlying risk. And this applies, and other considerations apply for small numbers, right, small counts, where typically changes from zero don't actually represent a change in risk, but just represent random processes. And we saw this most clearly, I think, in that recent death from West Nile virus, where we've had 0 reported cases for many years, and then we had 1 case. And the public may erroneously conclude that because there are 0 cases reported, there's 0 risk, and it's important for us to communicate that 0 cases in a given area in a given year does not necessarily mean 0 risk. When things are quite rare and uncommon, it's just the luck of the draw, how many, or in this case, very bad luck of the draw, how many cases actually occur, right? When you go to the casino and you keep pulling that slot machine lever and you keep losing, that doesn't mean your odds of winning are 0, right? It just means they're really low and you just haven't struck triple cherry yet, and then at some point you will. So our unfortunately, I know we put a lot of interest, we have a lot of interest in our case counts, but from an epidemiological public health perspective, we can very seldomly draw meaningful conclusions from those data year to year. Only in the event of a 5 or 10-fold increase can we typically say there's a problem here.
Okay. Greg, in these areas that they're identified in larger amounts, do they treat those areas?
Do we?
Yeah.
No.
No, but the park.
I'm not sure. That would be totally up to them to act on.
I think it's all surveillance. I think it's all for surveillance.
It's all for
Yeah,
surveillance.
what we do is just surveillance. They will
Right.
know the results and they can make a determination if that's something they want to do.
Okay, thank you.
Lastly, I did include the year-to-date, I forgot that. Our client feedback survey, so that's calendar year-to-date.
Which is very good.
Yeah.
So kudos to the staff for that.
Good job, guys. 4.84 stars.
Yeah, out of 5, that's
Out of
pretty.
5.
That's pretty good.
Absolutely, good job.
That's all. Items from our members. Commissioner Rushing.
Just humorous, because what you brought up, humorous but true about the mosquitoes. And I'm fortunate, we have 160 acres out in Riley. I got Bell River, about half a mile of Bell River. I go down there fishing or do stuff in the woods, and the mosquitoes will carry you away down by the river. But she has over 250,000 rocks, boulders and rocks, but she's got flowers and plants growing everywhere. She also had a custom sign made, God's Rock Garden. You come there, there is not a mosquito in her God's Rock Garden. She also will not allow any chemicals on the property. Said God doesn't want it, so she doesn't allow any chemicals. Over by my caboose, I put down weed killer so I don't have to take care of stuff. But for her garden, and you come out there, and we've had parties, and I don't believe you'd have any mosquitoes. You come out there and sit in our gazebo by the bonfire, and there's no mosquitoes. However that happens, but true story.
Anybody else have anything? Okay, then I would take a motion to adjourn. Support. At 11:13. Leanne and Carolyn?
Yes.
Was it, Carolyn, did you make the motion?
So moved, yes. And then.
And I'll
Leanne
support.
second. Okay. All right, it's been moved and seconded to adjourn. All those in favor?
Aye.
Aye.
Opposed? Thank you, everyone.